So there's some principles really that we tend to follow when we are considering medication for people with dementia, and I'll go through each one of these in their own kind of way. So the starting point is to remove toxic drugs, and which ones? There's lots of them, so we never know for sure, because most of our people with dementia have about 3 other chronic medical conditions, all of which need treatment. And many of the drugs that people are on when people are being treated with polypharmacy, as we know in Wanganui, is that they are there for a good reason. Most people are not on like 7 or 8 drugs because they've got bad doctors. It's because they've got good doctors who are following treatment guidelines correctly for 3 or 4 different medical conditions. So it's not as simple as it sounds that, oh, you will stop all these drugs and you'll be better, because they might die of a heart attack or something if we do that wrong. Certain drugs do affect people's cognition, and these are the drugs that we focus on. And so when I'm seeing a patient, the first thing we're really thinking about is looking at their medications and looking at what we might be able to discontinue. And this isn't a hierarchy in any particular order, but certainly anticholinergic agents are very toxic to elderly brains, and a person with dementia is likely to be worse if they're on a lot of anticholinergic drugs. And you can find tables in various places which has all anticholinergic drugs, which is an amazingly long table. And a lot of antihypertensives, beta blockers, things like that have quite a lot of anticholinergic effects. And you get a combined effect. So if you're on 3 different anticholinergic drugs, that's going to cause more confusion than if you're on just one. So things like oxybutynin, tricyclic antidepressants, things like that are particularly anticholinergic medications which can cause confusion. Analgesics. Lots and lots of people on tramadol these days, and codeine, Paracode. If you're on Paracodine, as your doctor generally prescribes it, you're getting 32 milligrams of codeine a day, which is actually enough to scramble a person's brain. So trying to remove medications like that if it's at all possible. A lot of elderly people are on small doses of morphine because they've got chronic osteoarthritis, because everyone can't find a better solution. Those kind of medications can actually contribute or aggravate confusion, so we will generally try and discontinue those types of agents if we can. Obviously, you may get to the point that you're trading off pain versus confusion. When you're treating people with Parkinson's disease, you're almost always dealing with a conflict of whether you got mobility or you're confused or hallucinating. So there's this dilemma happens all the time in medical treatment. Antihypertensives, the main issue most elderly people have with blood pressure is that it's too low and they fall over. And a lot of older people are on like 2 or 3 different antihypertensives, and then you add in one agent and then they fall over and break a hip, which is often fatal ultimately. So you're looking at blood pressure, thinking about blood pressure. If people's blood pressures are low, that can actually make them very vulnerable. With dementia, generally what happens over time is your blood pressure drops as the dementia advances. And so most of my practice, we're worrying about people with low blood pressure rather than high blood pressure. Getting onto the psychotropic type drugs, benzodiazepines, lots of people are on long-term diazepam, lorazepam, oxazepam, temazepam, and they're confused and they're presenting to you with confusion. You try and stop them. That's actually pretty difficult. My experience is if you reduce the dose and you don't see any change, probably stopping it's not going to make much difference. So if you've got somebody, say, on 10 milligrams of diazepam a day, if you cut it down to 5 milligrams and it makes no difference to their confusion, I'm not really going to battle away to try and stop those last 5 milligrams if it's going to be an issue, which it often is, because people become very kind of dependent, both physically and psychologically, on benzodiazepines. And the antipsychotics, well, we'll talk about them later on as well. I'm sure we'll talk about them lots because it's an issue of great concern. I mean, my concern about antipsychotics in people with, when you're presenting to you for the first time with Alzheimer's disease or dementia generally, are the anticholinergic and blood pressure lowering effects of them. So you are reducing them or stopping them for that reason. If somebody's got chronic schizophrenia, you're obviously not going to be in a hurry to do that. But you may think of changing to a less anticholinergic drug if they still need an antipsychotic. And then there are other agents, and lithium is a good example. There's very few people you see, you change their medication and they're cured of their dementia, but the one I've seen 2 or 3 times over the years has been lithium. So basically with lithium, usually people got bipolar disorder, and they've been managed on this level of lithium for the last 30 years, and say their level is 0.9 or something like that. Well, as your brain deteriorates, that 0.9 becomes toxic to your brain. Your brain doesn't have the same tolerance for lithium, and all the other drugs too, but lithium's a good example. So 0.9 is actually quite a toxic dose for somebody who's 85 with mild dementia. So sometimes stopping or reducing the lithium can actually make a big difference to a person's cognition. So there's a number of strategies you can do to treat or to improve the potential of somebody who's got dementia. Has anyone got any?
I have a question. You mentioned that as dementia advances, blood pressure decreases. Can you speculate on why that would be?
Not really. I mean, I could speculate, but I don't know the answer. I don't think anyone really does. I think it's a combination of factors. People tend to lose weight. They tend to lose physical condition. They're often on a bunch of pills which drop blood pressure. It is possibly related to the brain failing. I mean, what we do know in people with dementia is a whole lot of their normal controls of their body change. So we see people with dementia who don't eat. They just don't feel hungry. That reflex is not working. Or they don't sleep. They're awake all the time, or they sleep all the time. And again, the normal biorhythms are affected by the disease. We know that people with Alzheimer's disease, their immune system isn't as good as it used to be. So they're more likely to get horrible diseases. So it's probably in some way connected with that. But we also know that generally people, as they get dementia, as it advances, they tend to lose weight and they lose condition, and that might also be a factor. So the second part of that is reducing the risk. And what you want to do is you reduce the risk of things that can make your dementia advance more rapidly. So people who've got vascular disease, we know that vascular brain damage is a huge part of dementia. And we know that if you cut up the brains of everyone with Alzheimer's disease, you'll see that lots of them have got quite significant vascular disease in the brain. And we believe that one of the main reasons why a person develops Alzheimer's disease at, say, the age of 65 instead of the age of 75 is often due to vascular damage to the brain. So if you've got somebody who's got a history, say, typical of vascular dementia, so they've had some sort of vascular event and they dropped in their cognitive functioning and then they were kind of okay, and then they had another vascular event and they dropped a bit more. By reducing the risk of having another vascular event, you can actually stop the deterioration. And we do see that quite commonly in people who've had a couple of vascular events. They're quite cognitively impaired. They'd be diagnosed with dementia, but you can actually stop them getting worse by stopping them having little strokes. And so it depends how far you're prepared to go. People sometimes do carotid bypass surgery and do all sorts of things. Aspirin, simple interventions like that can make a big difference to the risk. And often TIAs, we get, I'm sure all of you get this, you get people turn up and say, oh, I'm sure I had a stroke. And they go to the ED and they say, hell no, there's nothing wrong with you, go home. But they're probably right. I mean, people are having small strokes which don't cause paralysis, and therefore doctors aren't really interested in it, but actually cause quite significant damage to the brain and actually can cause confusion and all sorts of things. And so if you've got a history like that, you will really try to look at vascular risk or try and maybe identify why they're having these little strokes. They might have atrial fibrillation or something like that, which can be managed. Alcohol. Basically, the science would say that if you've got any form of dementia, any type of cognitive impairment, you should never drink any alcohol ever again. So that's the short answer to that. So we go to the dementia units and they've got happy hour and they're slugging back a wine. And probably for those people who are demented and in a dementia unit, the horse is bolted, and it probably doesn't make any difference at all to their ultimate prognosis and gives them a bit of comfort and happiness. But if you're talking to people, you've got somebody in front of you who's got some sort of cognitive impairment and you think they've got mild dementia, I always ask about alcohol, and they always ask me, how much is it okay to drink? And basically, as your brain becomes damaged, it becomes more and more sensitive to the toxic effects of everything. And alcohol is the one thing that is most kind of available in our society as a toxic agent to the brain. And so, as I said, the science would really say you shouldn't drink any alcohol at all. Now, we've all read the science that drinking small quantities of alcohol may reduce your risk of dementia ultimately, but that's actually before you've got dementia. If you've got cognitive impairment, alcohol is bad for the brain. I'm actually really surprised that when you put it straight to patients, how accepting they are of the recommendation. You know, you're asking me, what can I do, doc? Well, I say you should stop drinking. And you should never have another drop of alcohol again in your life. Okay, and people often do it, surprisingly often. And we've seen a number of people, I've got a number of people I've actually discharged from our service who've actually done that and have actually improved quite markedly to the point that they are functioning a whole lot better. And these are people who are drinking 2 or 3 glasses of wine a day. These are not like rampant alcoholics. These are normal, this is Hawke's Bay. Normal Hawke's Bay citizens drinking, normal Hawke's Bay quantities of wine. And yet that can make a significant difference. And as I mentioned earlier about people who recover in the dementia units, it's usually people who've stopped drinking. And there's been lots of studies on alcohol in the brain. And probably my interpretation of the alcohol in the brain thing is that any alcohol is toxic to the brain. It's a neurotoxin, basically. And fortunately, we are resilient and we have good brains and we can resist the effects of alcohol for most of our lives. But we shouldn't kid ourselves that this stuff's good for us, good for our brain. Probably the reason why people are maybe a little bit less likely to develop dementia if they drink a glass of red wine is probably because the vascular risk is reduced. It's not that it's good for your brain. So taking that line, my advice to people is to be absolutely clear about it and not to waffle around, oh no, it's okay if you have a couple of glasses of wine at night. Because the truth is, the science is that it isn't okay. And smoking, that's a more difficult one because people really find that much harder to do than stopping alcohol. Again, smoking is a risk factor. The day you stop smoking, your risk of everything drops off. So your risk of cancer, your risk of destruction of your lungs, the risk to your brain, the risk to your vascular system reduces. So if people do stop smoking, it can make a difference. But generally, our experience is that people with dementia, it's very hard for them to change that pattern.
What about marijuana? Because that's being used an awful lot with older people as well.
Yeah.
I mean, which actually blows me away because it's sort of foreign to me, but I keep coming across people in their 60s who use marijuana regularly and have done it for many, many years. And what impact does that have?
Well, there's no good science, but marijuana is a toxin to your brain. We know that it is extremely damaging to the developing brain, which is why young people who smoke marijuana develop schizophrenia and all sorts of dreadful mental illnesses. We know it causes permanent changes to the brain, even at that age. You can be absolutely certain that it's a neurotoxin, exactly probably like alcohol. Whether it's better or worse than alcohol, don't know. But I mean, certainly it wouldn't be good for the brain. That would be my response to that. I'm surprised how few people I see who, I always ask them actually. Very few of them. I think I've got one patient who smokes dope and she's just never going to change that. And she's got early onset Alzheimer's disease, young onset Alzheimer's disease. And probably the reason why she's got Alzheimer's disease is either that she smokes or that she smokes marijuana. That's probably the main 2 risk factors she's got. So again, if somebody asks you the question, you should say, well, the science would say that anything that's toxic to your brain you should not use if you want to protect your brain. Anxiety and depression. Well, SSRIs, yes, good choice. Basically, we often see people get anxious and they often present with quite high levels of anxiety when we see them, and that may be related to a whole lot of things. So people who are confused get anxious. People who are in an environment that they're not comfortable with because they can't understand what's going on around them, which is a lot of people with dementia who are living at home in a flat when people come to the door and the phone rings, all these things causes an extremely high levels of anxiety. So sometimes putting people into a more structured environment or removing some of the stresses in life, they'll become less anxious. we're talking about drugs here, so I'm just focusing on drugs here. So our observation is that if treating anxiety, often people function a whole lot better, their quality of life improves. It doesn't cure their dementia, but they're often a whole lot better, and they often function better because they're not anxious all the time. So, and it's also very common early in the stages of dementia that people can often get quite severe depression. And so treating depression and anxiety, both medically and non-medically, can be very successful. It can make a huge difference to people's quality of life, and so it's something that we promote and encourage. We would generally use an SSRI, and our SSRI of choice at the moment is escitalopram, fully funded by PHARMAC, we greatly appreciate. And again, with these kind of medications, a bit on the line of the antipsychotics, you give somebody a trial of medication and you give it for a month, and if it's not made a really major difference, then you stop it, because you don't want people to be on drugs unnecessarily. If it's made a difference, if their quality of life and things have improved, then you generally carry on with it because it's probably doing some good. And as I said, we're surprised how well people respond to medication. We have a clinical psychologist in our team, so we don't just look at drugs. We've got a whole multidisciplinary team. Generally speaking, our experience with people with dementia, psychological treatments don't work very well. They forget what they were told, they forget what they learned. But changing environment, changing the social support, changing the caring arrangements, all of those things can actually have a big impact on mood and anxiety.
Excuse me, is it also start low, go slow with escitalopram?
Yeah. I mean, basically with escitalopram, generally we'd give them half a tablet, 5 milligrams to start with. After a week, I'd go up to 10 milligrams, and that's it. And you'd give that 3 or 4 weeks, and if nothing's happened, then you'd probably stop it, unless you think they've got a severe depression that needs more active treatment. But most people, you'd then think, oof, maybe this isn't really going to work, and you'd be looking more at environmental and structural things around them.
Why is your choice escitalopram as opposed to the other ones?
It's the cleanest of the antidepressants. It's got the least side effects. It's the best tolerated. It doesn't work any better than any of the others, but all the evidence would show that and sertraline are considered to be the 2 best tolerated antidepressants. Sertraline's a little bit more complicated to use because you've got 50 milligram tablets and 100, and you never know whether to go 50 or 100 or 200. Whereas escitalopram, you know, if somebody's getting 10 milligrams of escitalopram, they're getting a very good dose of an SSRI, and you know you've got them on, you know, you've done a good trial of treatment. Whereas you give somebody, you know, 50 milligrams of sertraline, you're never sure. But they all work just as well. And that just might be our fashion at the moment. It might change.
The trouble with escitalopram is recently had a foreign doctor come in and started on escitalopram, somebody 20 milligrams thinking it was citalopram.
So yeah,
Foreign doctor came and started somebody on escitalopram 20 milligrams thinking it was citalopram.
Yeah.
There's another issue there.
Yeah.
Also, what we found a lot with our presentations, either on admission or at rest homes, agitation tends to encompass a bit of that, and we tend to find when we're out there assessing clients who are actually on the ward, we find agitation is a big problem. We find a lot of our clients that is in with agitation is related a lot to pain, and we've had quite a good response with some of our more severe clients. Managing the pain has reduced all that as part and part. I think a lot of the rest homes get a bit of a pickle, they're either depressed or they're anxious, and sometimes it's agitation related to some underlying physical thing that they've possibly not thought of.
Absolutely.
Need more education, I think, is needed out there for these people.
You know, going back about, I don't know, 2 hours or 3, 4 hours ago, I mean, that's really what we're saying, is you're looking at the whole picture. So, I mean, we're talking about treating anxiety and depression with SSRIs, but that's the end point of thinking about all those other things. I agree. And you just do harm if you treat people inappropriately.
We tell people, start with the basics, stop looking at the big stuff first.
Psychosis. Well, about 30% of people with dementia will be psychotic at some point in the course of their illness. And it can occur at any stage. It becomes more often more prevalent when people get more advanced with their dementia. So psychosis is a very big issue. It's often connected with aggression. So quite often people who are physically aggressive, particularly if it's out of character, may be responding to some sort of delusion or some sort of misinterpretation of what's going on around them. It's kind of included in BPSD, which we'll kind of touch on a bit later. But people who are demented, who are delusional or hallucinating, that is something that you would want to consider treating, and you treat that with an antipsychotic. If somebody's psychotic, you need to use an antipsychotic, even though we are going to be questioning that later on. But basically, you treat them with a potent antipsychotic. Generally, we would use risperidone to treat psychosis because it's a potent antipsychotic. It's a bit like escitalopram. You know, if you've got a milligram of risperidone, you're getting a good whack of antipsychotic, and if those psychotic symptoms don't respond, maybe they're not going to, or maybe you've got it wrong, or maybe think about something else. Because if somebody is delusional or hallucinating, they may have a urinary tract infection or something like that. As I said, it is quite common as part of dementia is to be psychotic, which needs treatment, and it can make a huge difference to the patient and everyone else's quality of life. Challenging behaviours, BPSD. Well, BPSD is a huge kind of catch-all of everything. People wandering, people being sexually inappropriate, people bashing people, calling out. And so it's kind of been, I don't think it's a very useful concept because it incorporates so much. You shouldn't use antipsychotics for BPSD. Well, no, you shouldn't. But I mean, you should use antipsychotics for some components of BPSD. So BPSD is behavioural and psychiatric symptoms of dementia. So there's all sorts of things, and the first thing about it is you really want to focus on the behaviour. So if you're treating somebody with dementia, you're treating this person who is demented and is wandering around the rest home and going into other people's rooms and causing a ruckus. You're not saying, I'm treating this person for BPSD. You need to be really quite specific on what you are thinking about. And when you're thinking about that, you want to think about what you can or can't achieve. So if somebody is wandering around the rest home confused, drugging them up is not really going to help. So, you know, what do you want to achieve here? Do you want them to sit in their room quietly for the rest of their lives? Or do you want to put them in an environment where it's okay for them to wander around like that? And so that's the consideration. So the non-medical approaches, there's all sorts of things. You move them to a more structured environment. You give them the opportunity to interact with other people. You take them for a walk to use up some of that energy. All sorts of non-medical approaches. And then there's the medical management, which we'll kind of get to. And basically, the evidence base for all of this is pretty weak. So, and these guidelines, which I was partly responsible for writing, you know, you've got to use the non-pharmacological strategies first. Yeah, sure. We do. We try. Everyone tries. The evidence for the non-pharmacological strategies is weaker than the evidence for the pharmacological strategies, I'm very sad to say. But I still think that's what we should be promoting. And then the evidence for medical treatment of BPSD is weak. The evidence for medical management of people who are physically aggressive in a rest home with antipsychotics isn't quite as weak. And there is some evidence to support the use of those strategies. The evidence to give a drug to somebody who's in the rest home and calling out, help, 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 all the time with any drug or any strategy is actually pretty poor. There's not a lot of evidence. So we're all in a bit of a kind of a very grey zone with this, and there is a tendency in life to try and use simple strategies for complicated problems, and so there's a tendency to use drugs and pharmaceuticals for these kind of behaviours. Antipsychotics and dementia. Well, this is all the stuff which is in those things we sent around, which I helped write. And I'll have to front up and tell you what I actually do myself shortly. But basically, we know antipsychotics in people with dementia, people are more likely to die, and they're more likely to have cerebrovascular accidents. strokes type things, fall over, break things, than if they weren't on an antipsychotic. Most of that evidence is based on studies done in people with over the age of 80 with an MMSE score of like 3 and who are in hospital level of care. So these are very physically frail, advanced demented patients. So most of the studies showing this great surge of death with these drugs is from that. When you're looking at a group of 65-year-olds with mild dementia who otherwise in good health, there's no good evidence that these things increase their risk of death. And we know, for example, the chronic mental health population, the chronic schizophrenics, they don't have an increased risk of dying from antipsychotics. So having severe dementia is a risk factor for having bad reactions or bad consequences of being on antipsychotics. We know that untreated agitation causes people to die. So doing nothing actually isn't really an option for most of these people. There's research done on people with agitation and aggression and wandering and all sorts of things, and they were given risperidone, and mostly risperidone, haloperidol. Did show for some people that it helped. There's the evidence base that risperidone does reduce agitation, whatever that is, and aggression in people with dementia. In fact, that's one of its registered indications for risperidone. Quetiapine gets a bad rap. Everyone's on about all this excessive use of quetiapine in the elderly. In my advanced care directive, I think, if I've got to have an antipsychotic, please try me on quetiapine first, even though there's no evidence base for it, because it's a better drug. I mean, risperidone is a very potent antipsychotic, and people on 1 milligram of risperidone get sedated and they get drooling and they tip over with Parkinson's. And that doesn't happen so much with quetiapine. They might drop their blood pressure and they might fall over, but you're trading off side effects all the time when you're treating people. Give them benzodiazepine instead. When this whole thing came out about antipsychotics in Britain, they changed their prescribing pattern and gave people the lorazepam stuff instead, which is even just as likely to kill you as antipsychotics if you've got advanced dementia. What happened in Hawke's Bay, because we did a study before and after this whole stuff came out about antipsychotics, or risperidone it was, atypical antipsychotics. So people, the GPs, wasn't us, wasn't me, the GPs started using haloperidol instead, which is even more toxic, as it turns out when they did the study. So virtually everything we give to these people is toxic in some way. And I think we've then got to start thinking about, what are we trying to do here? This group of people, what are we doing here? You know, you talk to palliative care specialists, I mean, they just give people all sorts of stuff in vast quantities. You know, our people with dementia, particularly those ones who are in a dementia care unit, these people are at the advanced stages of their disease and they're near the end of their lives. And, you know, is it kind to leave these people in a distressed, agitated, restless state just so they don't maybe have some sort of potential risk of an event? And so in dementia, I don't think we've really got our heads around when we start doing palliative care. So I think it's actually pretty early on in the disease. So, you know, we see people, and I'm sure all of you do this every day. There's somebody at home, husband is demented and he's agitated and he's getting bolshy and he wanders off and he's aggressive. You know, and you say to the family, well, you know, give them haloperidol, give them risperidone. Makes a huge difference. And it does. Even though the evidence base is not strong, it can make a huge difference. And then what are we doing? We've given this person quality of life. They can maintain their independence, all of those things. So there's an argument each way here. As already outlined, you go for the lowest dose, you review it. If it's not working, you stop it. So basically, you want the stuff to work, and if it's not working, you stop it. And even the people who do respond well, so you've got somebody who's been really agitated and aggressive, you've given them risperidone, they're on 0.5 milligram risperidone, they've settled down really well, well, you'll still try and stop it. And, you know, we certainly try it all the time. So maybe 2 or 3 months down the track, you stop it, see what happens. And for many of those people, they don't need to be going on because, as we've already heard, you know, this disease tends to fluctuate, these behaviours fluctuate over time. So what do we do? Well, we use antipsychotics a lot, actually, I have to confess. We did do a study a few years back in Hawke's Bay, and we checked out all the numbers of people, the number of antipsychotics we were giving to our poor rest home residents in Hawke's Bay, and it was about, I think, 20% of people in Hawke's Bay were on an antipsychotic. And we weren't sure how good that was or not. But you look at any study done anywhere in the world at a rest home population, between about 15 and 25% of people are on antipsychotics. And I don't believe that everyone is a bad doctor and everyone's a bad nurse and every rest home is a bad rest home. It might well be that there is a certain number of people that need to be on these drugs at any one time. So yes, they get used, and as I said, the way we use them is we try and stop them and we monitor it closely. So you start somebody on whatever it is, you'll go and see them 2 or 3 weeks down the track, see if it's made a difference. And if it has, you may continue the treatment for a bit longer. At some point, you'll try and stop it. Yeah.
Can I just ask, is there a place for PRN use of antipsychotics?
I think all the evidence we have would say no. Having said that, it gets done quite a lot. I mean, antipsychotics are not good drugs for PRN use. I mean, they're long-acting, they don't work straight away. I'd say the only kind of circumstances that it's justifiable, if say you've got somebody on, say, quetiapine in the rest home, and they're on 50 milligrams of it anyway, and then there's an escalation in their behaviour to give a small increase in the dose, might be the circumstance that you might think about it. It's very difficult, because what else do you do? Now, do you give them lorazepam, which is even worse? So it is very difficult. So it gets used quite a lot. As I said, there's not any good research basis or rationale to support that.
So if someone's on regular antipsychotic and they're getting symptoms and there's some PRN prescribed, there is a need to get some PRN prescribed, would you use something like quetiapine because it's more sedating than some of the other ones?
No, you'd use more of the same whatever they're on. So if they're on olanzapine, you might give them the option of a slightly increased dose. And if that was being used all the time, you'd increase the regular dose. I mean, generally speaking, with antipsychotics, I think people need to be on a regular dose or not on it at all, generally speaking.
At a recent local CME, talking about antipsychotic prescribing for BPSD, because of the increased risk of vascular events and stroke, it was suggested that that was a discussion we should have with the patient's family about the fact that if they were starting this, it carried that increased risk. Practically, that's very difficult. Is that your practice?
Yes. Yeah. And just about every family says, bloody hell, what are you talking to me about this? Jeez, this person's got dementia, look at them. I'll do anything to make this better for her. That's pretty much the response. But yes, I think you should, if you have the opportunity to discuss that with people, I think you should. And I think you should always say, look, this is for a trial, you know, and unfortunately all the research would show the people who died straight away. They died within a 12-week trial, you know, and after that they weren't dying so much. But I mean, basically, I think you've got to be honest and say, but I mean, I also use that as the opportunity to discuss palliative care. You know, this person, we're not curing this person. We're not, you know, this person has got advanced dementia. They are dying. If you've got advanced dementia, you've got a life expectancy less than metastatic breast cancer for most people. You know, so you are dying. We want to make your life better and that person's life better. Because people who are agitated are not happy. Sorry.
Sorry, I just wanted to add to that discussion that I think one of the considerations with PRM medication is around where the person is and who's going to be making the decision about giving it, because it's how sound that decision is about when it's used.
Yeah, I agree. And again, I think if you are needing to be considering PRN regularly, you need to increase the regular dose. Or maybe the person needs to be on a regular antipsychotic.
So I was just wondering, sorry, for all the reasons that you've just outlined in terms of, say, quetiapine being an unapproved medicine, the family aren't worried about that generally in your experience too?
I mean, you know, you say to people, look, there's no real good research to say any of these drugs are any good. But in my experience, it can make quite a big difference. So I think we should give it a try. There are risks involved. That's the sort of conversation. And as I said, I've never had a family say, oh my goodness, you can't do that. Now give them risperidone instead. But I mean, yeah. I mean, virtually everything, it's like pediatrics. I mean, everything you give to kids is off-label pretty much, or it's never been researched. So it's the same with geriatrics. I mean, most of the drug trials of virtually everything we give frail old people with multiple pathologies have never been researched in that group. Yeah. Right, the last 5 minutes, dementia drugs. Is that it? Oh, yep, pretty much. So, yes. I mean, these are the dementia drugs that are available. My practice is that anyone with any form of dementia in the early stages will consider these medications. I mean, their indication is mostly for Alzheimer's disease. Vascular dementia has also been shown to have some benefit. The more vascular dementia, the less effective. That's my observation of these agents. People with things like Lewy body dementia or Parkinson's disease-related dementia seem to respond better on these drugs than people with Alzheimer's disease. So basically, because we know dementia is not a pure diagnosis for virtually everyone, it is worth considering these medications. Your expectation, what you're selling these people is, this is a drug that may stop things getting worse for a period of time. That's pretty much what you're actually offering. Some people, about 10% of people, get noticeably better on them. And I've seen quite a few people who've, you know, you walk back a month later and the family say, wow, that's just made a huge difference. And so it does happen. For everyone, ultimately, if they live long enough, the effect will the dementia will start deteriorating again. Well, it'll become manifest again that the person's getting worse. We used to, when people were paying for it privately, and it cost them $200 a month, when they started dropping below baseline again, we would tend to stop them. And then we saw quite a lot of them got a whole lot worse when we stopped them. So basically they were deteriorating parallel to probably the way they would have deteriorated before. And so when you stop them, they lose whatever had been held back, and they lose it within a few days. It happens really rapidly. So our practice is a longer approach because it's fully subsidized now, and it costs nothing, virtually. It's a very cheap drug now, donepezil, is that when people are deteriorating, even though they are deteriorating, we'll tend to keep them on. When they go into residential care, we tend to stop it, and sometimes you see people deteriorate really markedly at that point, so again, you might resume it at that point. So donepezil is the main one that's used. Now rivastigmine is now funded and in patches. I've got 2 or 3 patients waiting for me to get back there soon, and go and see them who haven't tolerated donepezil, but we're going to trial them on the patches now that they're available. Not that rivastigmine's any better. None of them are any better than the others. It's just that the patch is a transdermal patch, and so it's more slowly absorbed. They're less likely to get nausea than some of the people who can't tolerate donepezil. These drugs work at any stage in dementia. So, you know, you see somebody with, say, moderate to severe dementia who's living at home with their family who are managing, and they say, we want Nana to stay here for as long as possible. Is there anything we can do to do this? Well, these medications might help. If they stop things getting worse for a period of time, then Nana can stay at home for a bit longer. So they have a place. What I tend to do is you give them with donepezil, the 5 milligram dose for a month, and then increase it up to 10 if they're tolerating it. And then you probably give it about 4 to 5 months to get a sense of how things are going. If they're deteriorating, obviously, throughout that period, you'd probably stop it because it's not doing any good. In Australia, I think it's still the case. You've got to have a 2-point increase in your MMSE score when you've been started on donepezil in order to continue your subsidy. I've never seen anyone get a 2-point increase in the MMSE score. And when I worked in Australia, I said, well, how do you get around this? You just lie. That's all they said. But basically, we did a study in Taranaki when I was working there. We had a neuropsychologist who was very interested in this, and we did all sorts of complicated neuropsychological tests to monitor the effect of the donepezil. Well, we were using rivastigmine then, And then we kind of asked the families as a sort of a control, was, what do you think? And they said, oh, he's a little bit better, oh, he's a little bit worse. And they were 100% accurate virtually. So I don't get too fussed on the MMSE or MOCA or whatever score we're using when we're using these medications. You talk to the family, and if they're saying, well, actually things haven't gotten worse, things are going okay, they're probably about right. Or if they say, nah, they're just getting worse, things are just worse, and then they're probably right as well, and then you might still do some sort of cognitive test, but you can it's a fairly accurate measure of other people's observations. And the sorts of things that improve on these drugs is not your ability to remember 3 words for 2 minutes. It's often language or the ability to go through tasks, sometimes motivation, energy levels improve, sometimes mood improves on the medications. And so they definitely, in my opinion, have a real role in the management of dementia. Again, we would only think about these things if all the other aspects in their environment and their social and their carers are all appropriate. And generally speaking, my view on these drugs is that you want to use them in the early stages of the illness. If you want to stop this thing getting worse, you want to stop it getting worse when it's not a bad disease, as opposed to leaving it too long. And I think that's 1 o'clock. Any question? I hope to answer.
Yes. 2 really quick ones. With the resignating, do you have potential to get heart block and bradycardia the same as the connective?
When I was using it a lot, we didn't even think about it. But then we didn't think about it without Aricept at that time either. I think they probably, it is a class effect probably to some extent. It's not going to stop me.
Just the other quick question, starting donepezil, if they're on a beta blocker or a rate controlling calcium channel blocker, do you ever reduce that or just kind of watch things?
It depends. It's a bit, the old house of God, if you don't take a temperature you won't find a fever. It's like using SSRIs. You monitor the sodium, it always goes down, and then you've got to do something about it. So with the heart block risk, somebody who's got a real bad heart history, who's on a beta blocker, we often say, I don't think we can use this drug. So, but somebody who's in otherwise pretty good shape and maybe they're on a small dose of metoprolol, generally speaking what we would do is we would start them, but we would talk to them and the family about, look, if you're starting to get dizzy or anything like that, then you just stop it and we'll deal with it then. I think I've only had 1 or 2 people over the years we've stopped because of that. We've had quite a few people we haven't started because I think we've become intimidated by the by the sort of becoming a little bit more defensive. Yeah.